So the goals are really pretty simple. We're going to provide some basic knowledge today about pre-exposure prophylaxis and post-exposure prophylaxis for HIV, which are more commonly known as PrEP and PEP. And that's how I'll be referring to them as we're moving forward today. Answer any questions that you have and provide some resources moving forward at the end of this presentation. And really, the entire presentation should be something I hope that people can use not only to inform themselves, but to have conversations with your provider or your friends or acquaintances if you need to. So I also wanted to note that we borrowed very liberally from the San Francisco AIDS Foundation and the CDC for a lot of the information that's contained here. So we're going to go ahead and start with what is PrEP. So it's a prescription medication that you can take that it will keep you from acquiring HIV if there is any risk in any sexual behavior that's going on. There are 3 medications that are approved with PrEP. Truvada, which which has been around the longest since about 2012. There's now a generic version available of that. It's emtricitabine and tenofovir. Descovy, which is sort of the new Truvada. Both of those are made by Gilead. And then I'm probably not supposed to talk about that, so sorry. And then Apretude, which is the new injectable, and which is exciting because it's a new delivery system. But most of this presentation is going to talk about Truvada and Descovy because Apretude or cabotegravir hasn't really made it into the PrEP market significantly yet for insurance and cost reasons. So I think it's an exciting new option, but not something that's being used regularly, not only in the Valley, but in Central and Southeastern Ohio, which was where I practiced for the last 5 years, doing basically LGBTQ+ medicine. So all 3 of these medications are highly effective when they're taken as prescribed. They're very safe and generally well tolerated by most people. So Brett, next slide, please. So who can take PrEP? So the CDC guidance it's pretty broad. If you've had anal or vaginal sex in the past 6 months and you've had a sexual partner with HIV, have not consistently used barrier protection, or been diagnosed with an STI in the past 6 months, injection, if you inject drugs or have an injection partner that is living with HIV, if you share any needles or any equipment, or if you've been prescribed PEP, so you've had a risky exposure, and there's continued risk that's reported, or you've used multiple courses of PEP, it really makes more sense to be on PrEP so you have everyday protection. And according to the CDC, about 25% of the over 1 million people who could benefit from PrEP in the United States have a prescription for it. And I'm going to talk a lot about the United States today. There's a whole different discussion that we could have around the world in regards to PrEP, but we'll talk mostly about the United States and then specific to California and the Valley as well. But when I'm practicing, the way that I've looked at this is that the PrEP is for anyone who thinks that it is appropriate for them, and that can be something about perceived risk. Then people's risk perception can be very different. And I've also given PrEP for people to have peace of mind around having sex. So their actual sexual behavior might not from a medical perspective really be very risky from an HIV acquisition perspective, but at the same time, being on PrEP sometimes allows people to have sex without the fear that they've had before with sex. And that's the utilization of PrEP that's totally appropriate as well. So I mean, from what I want you to take from this slide is really there are some very specific indications for PrEP, but PrEP can be for anybody. Next slide, please. Now, how effective is PrEP? And about 99% effective when taken as prescribed. Now, there are a decent amount of studies out there where you'll see different numbers, especially in some of the older studies, but those are those had a lot to do with adherence and studies that were being done in different countries with different populations, but in people where there were detectable levels of PrEP, it's 99% effective in preventing the acquisition of HIV through sex, and about 74% effective in preventing in people who use injection drugs. It's less effective when not taken as prescribed. That doesn't mean that it's not effective at all when not taken as prescribed, but we certainly would recommend that you take your PrEP as prescribed by your provider, and we can talk about it. We'll talk about a couple of different delivery methods for PrEP moving forward. And one thing to know, there are some differences in indications between each of the PrEP options, Descovy, Truvada, and cabotegravir, but they're all very effective in reducing the risk of acquiring HIV through sexual contact. There may be some questions about the study of cabotegravir, the injectable versus Truvada. And that there was a study that was stopped early because it was found not only to be just as effective as Truvada, the injection, but actually even a bit more effective in preventing HIV. So we're talking about a really small sliver when both of them are 99% effective when used as prescribed. And the thought is that the injectable is more effective in that study design because the adherence was better. People were getting actual shots when they were going into the study, and so we knew exactly where they were and where their levels were. So next slide, please. Go back one, I think, maybe. So how long does it take PrEP to work? So this is a question that I get a good amount of the time. And for receptive, for anal sex or bottoming, what we recommend is about starting PrEP about 7 days before you would have any sexual contact that might increase your risk of acquiring HIV. For vaginal sex and injection drug use, the maximum protection is about 21 days. We're not really sure why that's the case with injection drug use, but the difference with anal sex and vaginal sex is based on absorption through mucous membranes and tissue. And there's no data yet on PrEP effectiveness sorry, I'm behind. There's no data for PrEP effectiveness for insertive anal sex or insertive vaginal sex at this time, and we don't know how long it takes for the PrEP shots to reach their maximum protection during sex. Sorry, I'm missing about a third of my slides sometimes as I happen to go back and forth between screens. So if you guys see me looking back and forth, that's what's going on and why I'm not running the slideshow today. So we'll go ahead and go to the next slide, please. So this is another thing that you'll hear about, and it's on-demand PrEP or PrEP 211. So one of the big things about PrEP is, protecting people based on where they are in their lives and their sexual experience, and things called seasons of risk. And sometimes it doesn't make sense for people to take Truvada or Descovy or take a pill every day. Because you might not have that much of an exposure, and people don't really want to take pills all the time if exposures are not going to be close to each other. So we'll do things like seasons of risk. So going on PrEP and then off PrEP when it doesn't make sense, while you might be in a monogamous relationship, or you might not be sexually active at that time. And then there's also a type of PrEP that's called PrEP 211, or you'll hear intermittent, non-daily, off-label, event-driven, but it's basically PrEP that's taken with sexual activity. So ideally, you take 2 pills 2 to 24 hours before sex, 1 pill 24 hours later, and 1 pill 24 hours after the second dose. And that's very effective for people that have a very good idea of when they're going to be having sex and don't really want to take PrEP every day. The scientific evidence on PrEP 211 really is only for Truvada, and it's only in men who have sex with men having anal sex without a condom. So it doesn't generalize across all the populations that we've been talking about, but in this population, it is extremely effective. It's non-FDA approved, and I'm not sure that it ever will be FDA approved, but it is endorsed by multiple societies and the guidelines from France, the UK, Canada, and Australia. And a recent French study with significant numbers showed no new HIV infections in the patients that were doing 211 PrEP versus every day. So it's definitely an option for somebody who isn't having as much sex that they want to take a daily pill. Note that it's only for Truvada, not for Descovy. Next slide, please, Brett. I think we might have skipped one again. Sensitive. So another big question that I get is side effects with PrEP. Short-term side effects, long-term side effects, and we'll go from here. So I've written a lot of PrEP prescriptions. Thousands of PrEP prescriptions, I would say. Most people who take PrEP don't have any side effects, at the start or moving through. But when they do have them, they're usually mild and resolved within the first 1 to 3 months. For Truvada and Descovy, the most common ones are listed here, but diarrhea, nausea, loss of appetite, fatigue, muscle aches and pains, and vivid dreams. And I think that the most likely one to stay is the vivid dreams. That sometimes people continue to have vivid dreams at times, with PrEP, but all of the other side effects usually are short-lived. I've only had to stop PrEP in probably 2 or 3 patients for side effects based on the medication. You can treat these with over-the-counter medications. And a common question that I get from patients that are transgender or non-binary, or using gender-affirming hormones is whether or not PrEP changes the way that those hormones work. And the answer is that it has not been found to reduce the effectiveness of hormones in gender-affirming care. So that's something that you might hear sometimes, and it's not true. Next slide, Brett. So there's also a discussion about longer term side effects, and this is something that we'll get to when I'm going to do a side-by-side comparison of Truvada and Descovy for people. But the possible long-term side effects, mostly when we're talking about Truvada, relate to some kidney health and slight weight loss. The kidney side effects are rare and almost always reversible, meaning if you stop taking Truvada, kidney function goes back to normal. So possible long-term side effects from Descovy can include weight gain and some increases in cholesterol, though these are not large increases in cholesterol, and the weight gain is probably 2 to 3 kilograms usually in the first year. So that's probably max of about 7 pounds, but 7 pounds is 7 pounds. So the other most common side effects with the cabotegravir injection really are around the site of the injection: pain, redness, swelling. Very few discontinuations in the studies based on side effects from the injection of the cabotegravir. Next slide. Thank you. So PrEP care. So this is something just sort of to take with you, have an idea of what should happen when you're going in for your visits or your testing, and when you're starting PrEP. So initial visit would be an HIV test, and that's a 4th generation antigen antibody test, which really is probably pretty effective about 2 to 3 weeks into an exposure. So it's looking for the not only the antibodies to HIV that your body develops with the actual antigen from the HIV virus. So that really is a test that usually within about 2 to 3 weeks would be positive. So there's a little window there where you could get started on PrEP and actually be HIV infected, and we would find that out really at your 3-month follow-up. We can talk a little bit more in depth about that later if we want to. We always test kidney function to begin with, and then 3-site testing, which means oral, rectal, and urine. And basically the way that I have this discussion is, any place anything's been going without a condom. So if and it's sort of like ordering off the menu, but if anything's been going anywhere, we like to pee in a cup or swab. And because about 70% of gonorrhea and chlamydia infections that we see are oral and rectal. So if you're not peeing in a cup, if all you're doing is peeing in a cup, we're missing a good amount of what's going on. And then at my first visits, I do hepatitis A, B, and C screens. Then at the 3-month visit, we do every 3 months is the same as an HIV test. And then 3-site STI testing, and again, based on exposure. So that's all based on what's been going on, and it might be different every time. At the 6-month visit, do the same thing, and then we would check kidney function. Then if you're older than 50 years, or your initial kidney function was a little bit lower than was lower than 90. So that's not a significant level of renal failure at 90, but it's just where we keep track of your kidney function a little bit more to make sure that you're on the right medication, because one of the indications for Descovy over Truvada is somebody that has a little bit of impaired renal function. And then at the 12-month visit, again, we do the HIV test, we do some STI testing. All patients get a kidney function test. And then I do repeat hepatitis C screening based on risk, which revolves around men who have sex with men, usually that are using drugs with sex, whether it's cocaine or methamphetamine, but usually stimulants, transgender women that are having the same exposures, and then people that are injecting drugs. We check hepatitis C yearly or with any concern. Next slide, Brett. I thought this would be a good time to talk a little bit about acute HIV syndrome. It's not, I think I've had one person in the time that I've been practicing LGBTQ plus health develop acute HIV in sort of the window that we started as PrEP. So it's really unlikely to happen if you're taking PrEP. But I wanted to just list the most common symptoms and just give you some stats that 2 out of 3 people that are recently infected with HIV will have a flu-like illness within 2 to 4 weeks of infection. These are the most common symptoms, and fever, tiredness, headache, sore throat, and swollen glands are definitely the most common of those 5, but these are the 10 most common symptoms that you would see with acute HIV. It will resolve on its own and is frequently not diagnosed because people aren't looking for it. Next slide, please. So I get a lot of questions about, so one of the reasons that people don't start PrEP, or I get a lot of questions about, how do I pay for PrEP, or it's so expensive, what is at least the perception, what should I do? So I tried to outline here in California and with Medicaid, ACA, and different levels of income, what it is that you would do to get your PrEP paid for. So if you have health insurance, you use your insurance. There's still some copay assistance things that you can apply for. No health insurance, check out eligibility for Medicaid or ACA plans, and then there are other manufacturer plans and medication assistance plans that we can use for people that have lower levels of income, and then their lab visits and their labs and testing and their visits are covered at community health centers through programs through the government. So an example of a community health center would be like Borrego or DAP. And then at any income level, so, no matter what your income is, there's a Ready Set PrEP government program that can be helpful for meds, and labs and visits can be somewhat subsidized at the community health center. So cost should not be the reason that someone does not go on PrEP. So I would say probably 2 or 3 times in the 5 or 6 years that I've been writing for a lot of PrEP, have I had a patient that we were really struggling to get the patient on PrEP based on cost. Other than that, it really has been something that we've been able to figure our way around. So, but it was from a perception perspective, it's one of the main reasons that people don't come in or don't necessarily pursue PrEP. Next slide, please, Brett. All right, so here I wanted to go through a little bit and look at Truvada versus Descovy, because it's really what about 99% of people right now that are on PrEP are on Truvada or Descovy, and just compare a little bit the two medications. So they're both 99% effective. And we talked a little bit before how Truvada is indicated for episodic or 211 PrEP. Descovy is not indicated for that. So if you're looking for an episodic PrEP, Truvada is your choice. The studies in Truvada are more extensive from an efficacy perspective than the studies for Descovy. So as you can see here on the slide, from a Truvada perspective, gay and bisexual cis men, trans men and women, they've really studied everybody who falls under the umbrella of might be wanting PrEP. And whereas Descovy is, the studies have been in gay and bisexual cis men and trans women, and there really haven't been significant studies other than that from a Descovy perspective. Aptitude, the cabotegravir, just as a side note, has had very extensive studies in men and women and transgender men and women. So they're really looking for a good cross section of people to be able to use the injectable if it becomes more readily or easily available. Next slide, please, Brett. So from a safety perspective, both, as we said before, both medicines have very low rates of side effects, and we've already talked about this, so I won't dwell on that. People with osteoporosis should avoid Truvada. Descovy is safer to take with osteoporosis, and then the injection actually would be the safest of all to take with osteoporosis. Kidney health, we talked about Descovy being the safer choice and people that could have any kidney dysfunction. And then we talked already a little bit about weight loss and gain. Truvada might cause a small degree of weight loss. Descovy might cause a small degree of weight gain. Next slide, Brett. Thanks. And then cholesterol, we talked about Truvada may cause small decreases. My experience has been that it's really not affected cholesterol too much, and Descovy is known to increase cholesterol a little bit. And then you get into the significant differences here right now between Truvada and Descovy, really are from a cost perspective. So there is a generic version of Truvada, which has really changed the way that this market works. And the generic version right now with the coupon from GoodRx, and this will vary depending on where you go, but it is around $49 a month for Truvada, and brand name Truvada and Descovy, you can see, are nearly $2,000. Now there are There are programs that can help with this cost, especially with Descovy, because it's still on patent through the manufacturer. So this has been something to navigate over the last year or two when Truvada has become generic, because some people have actually seen their costs go up a little bit because everything used to be covered when there was a manufacturer program for Truvada, and now they have a copay, and insurances really are, for the most part, appropriately putting people toward Truvada rather than Descovy from a cost perspective. And that's sort of getting to the point on the next line with the insurance coverage. Descovy, sometimes we have to do a prior authorization, and where we have to talk about whether someone hasn't tolerated Truvada or what risk factors that they have that make them more appropriate for Descovy. And then pill size is another, I didn't put a comparison picture in here, I'm sorry about that, but pill size is something that does make a little bit of difference for some people. The Truvada pill is probably about twice the size of a Descovy pill, so there is that, but that has not been one of the more effective ways for us to get a prior authorization. So, I would say try applesauce, cheese, or peanut butter. It tends to work if you're having trouble with pill size, depending on what you like. All right, next slide, please, Brett. I want to talk a little bit about post-exposure prophylaxis as well. What is post-exposure prophylaxis? It's, taking really a combination of HIV drugs to prevent HIV acquisition after a possible exposure, whether it's with sex, through sharing needles or injecting drugs, or after a sexual assault. PEP should be started as soon as possible after the exposure, ideally within 24 hours. With a window of 72 hours. And if it's close to that, I still do it because it's very effective in preventing the acquisition of HIV. If you're going in for a PEP appointment, for a PEP or a PrEP appointment, be prepared for a lot of questions about what sort of sex you have, what goes where, so it just be ready for any questions. Questions about if you know your HIV status of your sexual partner, if they're living with HIV, if you know what their viral load is, a lot of different things about. So any of those questions could be there, and any answer. If you don't know, you don't know. So it's I always err on the side of prescribing PEP. It's a little bit like when we talked before about PrEP. There's some very specific indications for prescribing PEP, and then sometimes from a medical perspective, I might not be quite as concerned as a patient might be about HIV acquisition based on exposure and risk. But if it's going to make the patient feel significantly better from a mental health perspective, I prescribe the drugs as well. So it can make a difference there too. So next slide, please, Brett. So how to take PEP. Now, the PEP needs to be taken exactly as instructed for 28 days. All the studies are 28 days. Don't skip doses. Do not double a dose if you miss one. And it's less likely to be effective if you miss more than 2 days. So some people do occasionally have some, the same starting side effects with PEP that you can have with PrEP, but we're a lot more prescriptive about making sure that you take PEP every day and consistently after a risky exposure, even if side effects are somewhat of a problem. Next slide, Brett. So I thought, just from a informational perspective, the baseline screening that we do before PEP is we do a rapid HIV test to make sure that we're not starting treatment on someone that's already HIV, living with HIV. Pregnancy tests if appropriate, liver and kidney function, and then we do hepatitis screening and STI screening as indicated, knowing that if the exposure was sexual and it happened like the day before, the night before, that's not the right time to do STI testing for this exposure. So whether it's gonorrhea, chlamydia, or syphilis, what we would do is we would be testing, and hepatitis as well, we would be testing for pre-existing sexually transmitted infections. You would want to have follow-up testing for any exposures to STIs with the actual PEP exposure would be 2 to 4 weeks later would be the optimal time to do STI testing following an exposure like this. Next slide, please, PrEP. So PEP regimens, CDC recommendations are really pretty simple. Truvada plus Tivicay, which is dolutegravir, an integrase inhibitor. It's a very common HIV treatment regimen. Truvada, and the other one is Truvada plus Centris twice daily. I never use that because it's a twice, you have to take Centris twice a day. People don't always remember to take a medication twice a day. And then Biktarvy is off-label. Biktarvy is bictegravir. It's a bictegravir plus Descovy. So but it's all in one pill. So the most common PEP regimens that you'll see are you take a Truvada pill and a Tivicay pill at the same time, or you take a Biktarvy pill once a day. Make sure you get the full 28-day course. Sometimes if you go for a PEP exposure and you go to the emergency room, I'm not as familiar with emergency room practice here as I am in Columbus and Cincinnati, Ohio. But one of the challenges that we often had there would be that they would provide patients with 7 days of PEP, and then they would be on their own to figure out how to get the remainder of the 28 days that they needed. Usually a community health center or your physician can help you out, but I would really press to get the full 28 days if you would be in that situation at an urgent care or an ER. And then we also talk a little bit here about the PEP to PrEP regimen. This is another reason that I like to use of these regimens, Truvada and Tivicay, because you can at that point, if someone is appropriate to continue on PrEP after they've been on PEP for an exposure, you just finish the 28 days of Tivicay and continue taking your Truvada, and you're already on PrEP. We do an HIV. You can move to the next slide, Brett. We do an HIV test that, because I knew this was what it was. HIV testing follow it 4 to 6 weeks, and then 3 and 6 months, and then a hepatitis testing at 6 months. And as we talked about before, STI testing, again, 2 to 4 weeks post-exposure, because you want to check for STIs from the actual exposure that we prescribe the PEP for. And then with a follow-up test at 6 months, because sometimes syphilis test 6 months, because sometimes that can take a little bit longer to present itself. How to pay for PEP. So in PEP, in many states, it's covered by insurance. If there's any problems with insurance, there are some assistance programs that are run by various manufacturers. A lot of times that these can be challenging to navigate on your own within a 24 to 72-hour period. So at that point, if you're a patient, obviously with me or at Eisenhower here at Rimrock, it would be something that we could help you with. But if you weren't, my recommendation would be to go to a community health center or the AIDS service organization in the Valley because they can help you to navigate this and get the medication that you need in the amount of time that's appropriate to start post-exposure prophylaxis. So I also wanted to talk a little bit about U equals U in this presentation. So U equals U is a campaign that's been going on for a few years. Basically, it's undetectable equals untransmittable. It's basically, if you have an undetectable viral load and you're living with HIV, you can't pass HIV to a sexual partner. So undetectable really means that there's so little quantity of HIV in the blood that you can't find HIV in that sample. For the purposes of the study that these were done in, undetectable is less than 200 copies of HIV in a sample of blood. Undetectable, for people that are familiar with what undetectable means, at most labs, including Eisenhower's, is less than 20 units. But as long as the viral load is less than 200 copies, people can't transmit it to a sexual partner. We don't know how much U equals U prevents transmission through sharing needles. These studies were done with sexual exposure, and there was thousands and thousands of patients and hundreds of thousands of sexual encounters, and there was no transmission between partners where one was undetectable and one was not living with HIV. So it's just the other place that you'll hear this is, just treatment as prevention. So what that is, making sure that people are on their HIV medications so their viral load is as low as it possibly can be. So you decrease the amount of virus that is circulating, in the community, and it's less likely to transmit from one person to the other. Those are all, these all come from this undetectable equals untransmittable ethos, and the studies that have been done, and basically all comes down to meaning the same thing. If a person living with HIV is virally suppressed, they can't transmit HIV through sex to another person. So next slide, please. So that's the end of this part of my presentation. So I think we're going to open it up for some questions if anybody has any. And then after this slide, there's one more, I think. And then I put a bunch of resources here. So whether it's San Francisco AIDS Foundation, CDC, PrEP and PEP guidelines, and then the ISUSA guidelines as well. So anyway, thanks everybody for attending today. And I think that Brett or Guillermo was going to help us out with any questions.
Yeah, we have a few questions in the chat, and then we'll open up for some live questions as well. But just as a reference on this resource slide, I will go ahead and we'll copy this, and Guillermo, because the recording will take about 7 days, I'll go ahead and send this information to Guillermo. We'll send it out to everyone who registered for this by tonight or tomorrow morning at the latest, and you'll have these references. The first question that came in, it says, Dr. Braun, it says, may I start and stop taking PrEP depending on my sexual activity?
So absolutely. And that's sort of the seasons of risk discussion that we're talking about. So I think that that's a discussion to have with your provider. I like to have that discussion with patients, whether it's based on if they're not having sex, or if you get into a relationship, a monogamous relationship, and you feel like that Truvada might not be or PrEP might not be necessary for you anymore. A lot of times, I'm 54 years old, so I've been living around for a little while. So I usually say give the relationship at least a year, and we'll see where we are is usually my advice. But you definitely can have seasons of risk, so go on and off PrEP, or talking about 2-1-1 PrEP, or sometimes people go on vacations, or they go on cruises, or they go on somewhere where they know that their level of risk might be higher. So you might start Truvada 7 days before you go on your cruise, and then it might not be indicated for a few months after that. Those are discussions you can have with your provider, and then manage that in that way. Knowing that you have a little bit more flexibility with Truvada than you do with Descovy from an episodic perspective.
Great. Follow-up to that is, if I plan to party Friday night, when should I start taking PrEP? Friday morning, okay?
If you're using the episodic PrEP, Friday morning is okay, and I would continue that through 48 hours after any exposure. So that it probably depends on how long your party lasts. So some parties last longer than others, and the number of parties that you're having. So if you're having more than one party a month, I might consider taking something every day. But if it's one party every every few months, you would want to either start it 7 days beforehand, or but if you're doing episodic PrEP, you really should be able to take it 2 to 24 hours beforehand. The closest to 24 hours that beforehand that you can be, the better. But it's been been effective as much as 2 hours beforehand.
Great. Any known drug interactions with PrEP and monkeypox vaccine or TPOXX treatment?
Well, if you're on TPOXX, you probably shouldn't be having sex. So that's we'll start with that, because you're being treated for monkeypox. But I would have to look. I don't think so. I can do a little bit more research into that. But we weren't giving anybody any special advice when we were treating them for monkeypox with TPOXX that were on Truvada or Descovy or on HIV medication, any HIV medications from an interaction perspective. But if you're on TPOXX, you shouldn't be having. You probably shouldn't be at. Ideally, you're not having sex with another partner.
Great. Question that comes is, could you talk a little bit about lasting immunity from Truvada after taking it for, say, 3 months? I guess there's some online things that are out there in regards to that.
Yeah, Truvada is good as long as you're taking it every day. You'll have a little bit of protection after you stop for a few days, maybe a little bit more with Descovy than Truvada, but it's in the days. So once you stop taking the oral medications, the lasting immunity from that is in the days. From an injection perspective, it's longer than that, and that's one of a little bit of a plus, but probably more of a problem of the injection, because it opens the door to resistance to cabotegravir based on lower concentrations and then acquisition of HIV. So you have the cabotegravir in your system not at the high enough level, and you acquire HIV. That's how resistance happens. So but the answer to that is it's in the days.
Okay. Are there, this is an age-related piece, are there any special considerations for Truvada for people over 70?
So this is something that I think about. I start thinking about it at 50 when I'm looking at Truvada versus Descovy. When I start looking at it, I just got a 10-minute sling. I start looking at it at about 50. If the patient has normal renal function, they still could be on Truvada above the age of 50. But I do start using Descovy more often as kidney function, because kidney function does your kidneys become less functional as you get older. It happens even if you don't have kidney disease, your kidney function will go down. So it'd be much more likely to use Descovy in somebody that's over the age of 50, or anybody whose GFR, which is the glomerular filtration rate, the way that we measure kidney function a lot of the time, is less than 60, is indicated to be on Descovy versus Truvada. So
thank you. That's it for the chat questions. Are there any, if there's any live questions from anyone or anyone who would like to unmute themselves and be respectful of others and just ask a question of the doctor, please do so at this point. Feel free to use the chat as well, but if you want to unmute and ask a question, please do so. All right. No, yes, I see. Is there?
I just want to apologize for sitting in the dark. I didn't do that intentionally.
No worries.
I think it seems a bit rude, so excuse me. And thank you very much for an excellent presentation.
Thank you. You know, it's I've done a lot of medical education in my career, and the last 2 years have been super interesting, from a learning how to do this stuff from a over Zoom, and it's an interesting way to do this for somebody that's done it in person their whole life. So it didn't faze me at all. You know, for a room of students where all of it, usually I'll see like just face pictures all the time. But I do appreciate I appreciate everyone joining and joining live. Thank you.
All right, oops, maybe have another, hold on a sec here. Just some thank yous that came in. Very informative session. Thank you from many people. And your nurse, whichever nurse that is, someone is very happy about the presentation. So, and what we would do is we will, as I said, Dr. Braun is at the Rimrock location. He'll also be in the Arduous and La Quinta location for appointments at different times. And so what I'll do is I will send these resources as well as our World AIDS Day podcast out to everyone. I'll send it to Guillermo tonight, and then it'll go out to everyone who registered for this on both sides, whether you did it through Eisenhower or did it through the LGBT Acute Center, and we'll have all that for you by morning, if not soon. Right. Well, it looks like, unless there's a Guillermo, do you have anything that you'd like to?
No, I just put on the chat the email for programs at the Center CV. Somebody wants to receive the recording of this, and once it's available in the website on Eisenhower, I will send an email to everybody.
Great.
And thank you, Doctor, for your time and your great presentation. We appreciate that.
Yes.
I appreciate it. I appreciate it. Thanks for joining and for the opportunity, and please use this as a resource moving forward. So have a great night, everybody.
You too. Thank you, Doctor. Appreciate it.
Thank you, everyone. And our next and last lecture of the year will be December 14. I'll see you soon.
All right. Have a good night, everyone. Thank you.